Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 273 of our pharmacotherapy series, which majors in TB in human immunodeficiency virus infection. The first question reads, MEF is a 25-year-old Hispanic woman who is being treated with isoniazid 900 mg and rifampin 600 mg twice a week for pulmonary TB. She completed 2 months of therapy with isoniazid, rifampin, pyrazinamide, and ethambutol, and began the new regimen 2 months ago. She recently became pregnant, and her obstetrician is concerned about the possible teratogenic effects of her TB regimen. What are the risks of TB and its treatment to the mother and the fetus? Are these drugs teratogenic? Although concerns about the use of any medication during pregnancy always exist, it is now recognized that untreated TB represents a far greater risk to a pregnant woman and her fetus than the treatment. TB is one of the leading non-obstetric causes of maternal mortality. The World Health Organization recommends that treatment of TB in pregnant women should be the same as that for non-pregnant women, with few exceptions. Isoniazid, rifampin, pyrazinamide, and ethambutol are not teratogenic in humans. In the United States, pyrazinamide is not recommended for use during pregnancy because of insufficient safety data. If pyrazinamide is not included in the initial treatment regimen, the minimal duration of therapy is 9 months. All pregnant women receiving isoniazid should also receive pyridoxine 25 mg per day because of the possibility of peripheral neuropathy. Streptomycin should not be used during pregnancy except as a last alternative because it has been associated with mild to severe ototoxicity in the fetus. Ototoxicity can occur throughout the gestational period and is not confined to the first trimester. With the exception of streptomycin ototoxicity, the occurrence of birth defects in women being treated for TB with the above agents is no greater than that of healthy pregnant women. Therefore, administration of anti-tuberculosis drugs is not an indication for termination of pregnancy. Because MEF likely became pregnant after completing the first 2 months of therapy, she should continue her current regimen for a total of 6 months because she received pyrazinamide as part of the initial regimen. Let's now briefly look at multidrug-resistant tuberculosis in pregnancy. Little is known about the efficacy and safety of second-line drugs for the treatment of MDR-TB during pregnancy. 2 reports with small numbers of patients have suggested that treatment is effective with no adverse effects to mother or child. In a study of 7 women treated for MDR-TB during pregnancy, no obstetric complications or perinatal transmission of MDR-TB was observed. 5 women were cured, 1 experienced treatment failure, and 1 stopped therapy prematurely. No evidence of drug toxicity was seen among their children exposed to second-line drugs in utero, although 1 child was diagnosed with MDR-TB. There are no well-controlled studies with bedaquiline in pregnancy, therefore, the drug should only be used in pregnancy if clearly needed. More data are needed, but pregnancy should not be a limitation to the treatment of MDR-TB. We will now look at lactation. When the baby is born, MEF may breastfeed while continuing her medication. Drug concentrations in breast milk are minimal and do not provide sufficient quantities for the treatment or prevention of TB in the nursing infant. The next question reads, IAM, a 3-year-old African-American boy, is suspected of having TB. His father has been receiving treatment for TB for the last 2 months. IAM has a productive cough, fever, and general malaise. His sputum is positive for acid-fast bacillus, and his PPD skin test is positive, that is 10 mm. What is the incidence of TB in children? How should IAM be treated? The incidence of TB in children younger than 15 years of age has declined from 1,660 cases, 2.9 in 100,000 population in 1993 to 460 cases, 0.8 in 100,000 population in 2014. Children commonly have active TB disease as a complication of the initial infection with Mycobacterium tuberculosis, and the disease is characterized by intrathoracic adenopathy, middle and lower lung lobe infiltrates, and the absence of cavitation on chest radiography. Because of the high risk of disseminated TB in infants and children, treatment should be started as soon as the diagnosis of TB is suspected. In general, regimens recommended for adults are also recommended for infants, children, and adolescents, with the exception that ethambutol is not used routinely in children. Ethambutol is often avoided because it is difficult to assess visual acuity in children. IAM should be started on isoniazid 10 to 15 mg per kilogram per day, rifampin 10 to 20 mg per kilogram per day, and pyrazinamide 15 to 30 mg per kilogram per day. Many experts prefer to treat children with 3 drugs rather than 4 in the initial phase because the bacillary population is usually lower than in an adult and it may be difficult for an infant or child to ingest 4 drugs. If resistance is suspected, ethambutol 15 to 20 mg per kilogram per day or streptomycin 20 to 40 mg per kilogram per day should be added to the regimen until susceptibility of the organism to isoniazid, rifampin, and pyrazinamide is known. Pyridoxine is recommended for infants, children, and adolescents who are receiving isoniazid. If resistance is not suspected and drug susceptibility is confirmed, IAM should receive the isoniazid, rifampin, and pyrazinamide daily for 8 weeks. He can then continue to take the isoniazid and rifampin daily or 2 to 3 times a week via DOT for an additional 4 months. The dosage for isoniazid and rifampin in a 2 to 3 times a week regimen would be 20 to 30 mg per kilogram per dose and 10 to 20 mg per kilogram per dose, respectively. IAM should be examined routinely for signs and symptoms of hepatitis. Although anti-tuberculosis medications are generally well tolerated in children, LFTs are commonly 2 to 3 times the upper limit of normal during therapy. These are often benign and transient. However, the incidence of hepatitis in children from isoniazid with rifampin may be 4 to 6 times more common than in children receiving isoniazid alone. Most hepatitis occurs within the first 3 months of therapy and generally is associated with higher than recommended doses of isoniazid or rifampin. Children and adolescents should be screened for risk factors for TB using a questionnaire, and they should be skin tested with 5-Tu of PPD if one or more risk factors are present. Insufficient data are available to recommend use of interferon gamma release assays in children. Isoniazid for 9 months is recommended for treatment of latent TB in this population. Daily rifampin for 6 months is an acceptable alternative, especially in children who cannot tolerate isoniazid or those exposed to a source case whose isolate was isoniazid resistant. The next question reads, RUM is a 64-year-old, 82-kilogram man who is brought to the emergency department after a 4-day period during which he became progressively disoriented, febrile to 40.5 degrees Celsius, and obtunded. He also had severe headaches during this time. Physical examination revealed moderate nuchal rigidity and a positive Brudzinski sign, that is, his neck is resistant to flexion. An initial diagnosis of possible meningitis was made, and a lumbar puncture ordered. The cerebrospinal fluid appeared turbid, and laboratory analysis revealed an elevated protein concentration of 200 mg per deciliter, a decreased glucose concentration of 30 mg per deciliter, and a white blood cell count of 500 per microliter, with 85% lymphocytes. A gram stain of the spinal fluid and a sputum smear for acid-fast bacillus were negative, but the acid-fast bacillus smear of the CSF was positive. Other laboratory tests were within normal limits. A diagnosis of tuberculous meningitis was made. Discuss the presentation and prognosis of tuberculous meningitis. How should RUM be treated? Tuberculous meningitis is only one of the extrapulmonary complications of infection with Mycobacterium tuberculosis. Successful treatment of extrapulmonary TB can usually be accomplished in 6 to 9 months with an acceptable relapse rate. Some forms, such as bone or joint TB, miliary TB, or tuberculous meningitis, may require 9 to 12 months of therapy. Because specimens for culture and susceptibility testing may be difficult or impossible to obtain from a site, response to treatment must be based on clinical and radiographic improvement. Tuberculous meningitis in older persons is usually caused by hematogenous dissemination of the tubercle bacilli from a primary site, most commonly the lungs. In its early stages, tuberculous meningitis often is confused with aseptic meningitis because the gram stain is negative. The most common symptoms of tuberculous meningitis are headache, fever, restlessness, irritability, nausea, and vomiting. A positive Brudzinski sign and neck stiffness may be present. As illustrated in RUM, CSF is usually turbid with increased protein and decreased glucose concentrations. There is an increase in the CSF white blood cell count with a predominance of lymphocytes. Culture of the CSF for Mycobacterium tuberculosis may not be helpful because rates of positivity for clinically diagnosed cases range from 25% to 70%. Early recognition and treatment are essential for a favorable outcome. Thus, empirical treatment before receipt of confirmatory culture and susceptibility results is common in suspected tuberculous meningitis. Multiple drug therapy should be used because irreversible brain damage or death can occur as soon as 2 weeks after the onset of infection, not clinical symptoms. We will briefly discuss the treatment. Treatment should be initiated in RUM with daily administration of isoniazid 300 mg, rifampin 600 mg, pyrazinamide 2000 mg, and ethambutol 1600 mg for the first 8 weeks. After this initial phase of treatment, RUM should receive daily isoniazid and rifampin for an additional 7 to 10 months, although the optimal duration of therapy is unknown. In addition, because RUM is older, pyridoxine 10 to 50 mg per day should be given to prevent the occurrence of peripheral neuropathy from isoniazid. It should be reiterated that rifampin can impart a red to orange color to the CSF. Isoniazid readily penetrates into the CSF, with CSF concentrations reaching up to 100% of those in the serum. Rifampin is often included in tuberculous meningitis regimens and may be associated with reduced morbidity and mortality. However, even with inflammation, CSF concentrations of rifampin are only 6% to 30% of those found in the serum. Ethambutol should be used in the highest dosage to achieve bactericidal concentrations in the CSF because its CSF concentrations are only 10% to 54% of those in the serum. Streptomycin penetrates into the CSF poorly even with inflamed meninges. Lastly, we will talk about the use of corticosteroids. Corticosteroids in moderate to severe tuberculous meningitis appear to reduce sequelae and prolong survival. The mechanism for this benefit is likely owing to reduction of intracranial pressure. Dexamethasone 8 to 12 mg per day, or prednisone equivalent, for 6 to 8 weeks should be used and then tapered slowly after symptoms subside. Corticosteroids are likely indicated for RUM. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 274.